Good afternoon, everybody. I hope you are doing well in this difficult time and enjoying this sunny day. We've got sunny day today in Cardiff, and hope you're enjoying your sunny day, you know, whether you are at work or sitting at home. And I would like to thank Professor Tipton and the team at Tipton Training for giving me this, for facilitating this webinar today. Which I will talk about zirconia versus lithium disilicate, where and where. And before I start, a brief about myself. I am Dr. Aziz. I finished my BDS about 14 years ago from Iraq, and I worked both in dental practices and also I worked as a lecturer, both overseas and here in the UK. I got MSc in prosthodontics from Iraq, and I finished my PhD from Leeds in 2018. And my main area, my main research project was about zirconia for fixed prosthodontics. So over the next 45 to 50 minutes, I will talk to you about dental ceramics nowadays, about different definitions, classifications, and I'll be mainly focusing on the types and uses of zirconia nowadays. So in addition to the most commonly used dental ceramic available in the market and most commonly used one, which is the lithium disilicate, which is known, most of you will know as Emax. During the presentation, I'll try to pose some few questions and I will look into the chat box to see if you can post your answer. And please feel free if you want to answer, or if you don't. It's not like about examining you, but just to make it more fun, more entertaining, rather than just like keep me talking for the 50 minutes and it's going to be a bit boring, especially at the beginning. We're going to talk about history, something like that. So we'll ask you a few questions, and if you can answer, that would be great. Right. Okay, we'll start with the first question now. Right. If you look into this photo, my question to you, what you can see, what is the first thing attracted you? If you can post into the chat area, that would be great, so I can see what is the first thing attracted you. Right, okay, we've got some answer coming now. Right, okay, I expected answer to be most of you are answering that, the missing tooth. So, which is really very obvious, okay? So what about, you know, if think about, we are replacing the missing tooth. What about the eyebrow? Anybody has noticed the eyebrow, the missing eyebrow? Right, okay, so, well, this is probably highlight, you know, how important is the teeth. So the first thing that attracted you, probably because you are a dentist, or the other reason probably because it is the most visible. So if you got the choice, now if you know, if you've been given the choice to fix only one thing in this, for this patient, with either to do the upper right central incisor or to do the eyebrow, which one are you going to choose? Right, okay, so, well, I think different people have got different opinions. And simply you can, you know, you can get, if you say, well, I'll fix the upper central incisor, somebody will argue, okay, what about the eyebrow? So that's going to be more visible. So, you know, it's really difficult to say if you have to choose one of them. Yeah, I'm simply because, you know, as I mentioned earlier, so, you know, the missing tooth can be really picked very easy, more easily than the eyebrow. And nowadays, getting the patient satisfaction, especially for aesthetic and in the aesthetic zone, and the aesthetic demand of the patients are really high, and it's becoming more challenging. And that's why all of us as a dentist, we are always trying to get like the most, and to use the most aesthetic material probably for our patients, just to get the patient satisfaction. And to be honest, aesthetic demand, the high aesthetic demand, is the main driver behind the development of most of the new dental material in the market available at the moment. And you know, yeah, it's most, as I mentioned, it is most the main driver, and that it's been reported, and it's been like, I mean, I would say, like, it's evident in the research that unhappiness with the aesthetic is one of the main a problem the patient facing in dentistry. Right, I'm just going to move now. Right, okay. So hopefully by the end of this webinar today, the learning objective of my webinar or my lecture will be to learn about different definitions and classifications of dental ceramic available in the market, learn about different types of dental zirconia, and to learn about lithium disilicate, what is lithium disilicate, what is used for, and also to learn what material to use in different technical scenarios. I won't be able to cover like, as many as clinical scenarios, but I will try my best to give you like a general idea or a guide which material to use in certain type of patients. Right, to start with ceramic, so the word ceramic derives from the Greek term keramos, which means something to burn, basically. It means a potter or pottery, which was in an old Sanskrit root, meaning something to burn. And it's been available for a long time. It's been used by humans for different purposes. Now I've got another question for you. Before I talk about the history of development or the evolution of dental ceramics, so what type of material this denture is made of? If you can post your answer in the chat box, that'd be great, so I can have a look on it. Right, okay, a couple of you got it right. So basically it is ivory. It's made from ivory, and the ivory is the most common material being used in the 18th century for constructing denture or teeth for the denture. Talking about the evolution of dental ceramics, as anything, when you would like to find it about the history of something, it's always there's a controversy in the history about specific topic or subject. I tried my best and to get you the most, I would say, agreeable, history of dental ceramics. As I mentioned, in 18th century, the most usable material was ivory. That was used for making denture and for replacing teeth. However, the dissatisfaction of a pharmacist called Giacometto, who is a friend for a French dentist called Nicolas, both of them led both of them to collaborate and result in the fabrication of the first dental porcelain. And that was in 1788. And here we can see the dentist is Nicolas demonstrating his porcelain dentures on a buxom lady for a potential client, for a potential client who inspects them through his double lorgnettes. So probably there was no Specsavor at that time, and that's why he's using his lorgnette. In 1838, Elias Wildman formulated a more translucent ceramic with shades much more related to natural tooth appearance. However, well, saying that again, it was very opaque, compared, but they comparing it to the previous ceramic, they say it's more related, but it wasn't that much related in reality. So it's not been used for a long time. In 1889, Charles Lamb patented the first all porcelain crown termed the jacket crown, which is the material where enhanced progressively and was widely used up to 1950s. But the main problem with the marginal fit and the internal micro crack during cooling phase of constructing this material was that the main drawbacks and behind the stopping using of this material. In 1950s, Abraham Weinstein developed the porcelain fused to metal PFM, which is still being used nowadays, and one of the main restoration or main of the material used to restore missing teeth or used for a crown, and it's regarded as the gold standard for most of the type of crown replacements. In 1965, MacLean and Hughes developed the new version of the porcelain jacket crown that had an inner core of alumina porcelain. Again, its high opacity was also a major drawback. Late 1980s, highly site containing ceramics Empress 1 has been developed by Ivoclar, which has, this is regarded the first point in the developing of the new material, and it was the first pressable ceramic material. In 1990s, Nobel Biocare introduced the Procera, which is the all ceramic core material mainly composed of alumina. and usually it's been layered or veneered by lithium feldspathic ceramic. In 1998, Ivoclar introduced the IPS Impress system, Impress 2, which is mainly consists of lithium disilicate, which is still being used up to date, and the most commonly used material nowadays for crown on veneer, and available in IPS, Emax, CAD, or press. Right, okay, so I know that history might be not really enjoyable, but now we're going to talk about the new era of dental ceramic in the millennium era, where it started late 90s, in early 2000s. Zirconia came into the market by different manufacturers, and also alongside the IPS Emax system, which is being developed by Ivoclar Vivident. And since then, a tremendous effort has been employed to take out the metal out of prosthetic dentistry and to maintain it to the all ceramic restorations. So and it's still ongoing. So that the zirconia now available in many times. We're going to talk about that later on. But before that, we're going to talk about defining dental ceramics. What is the dental ceramics? Ceramics have been, with this is the definition that's been there for a very long time, have been traditionally been defined by the American Society of Ceramics as inorganic, non-metallic materials which are typically crystalline in nature and are compounds formed between metallic and non-metallic elements. However, due to the new development of a lot of new material came into the market in the last years, including ceramic, I would say ceramic-like material. Basically, it's a polymer contained high refractive materials such as glass or porcelain fillers. ADA came up with a new definition for the dental ceramics, which is pressed, filed, polished, or milled materials containing predominantly inorganic refractory compounds, including porcelains, glasses, ceramic, and glass ceramics. Right? Okay, so we got two definitions, and the classification, we're going to talk about the classification later on. Now the classification, because a lot of material now available in the market, it's very difficult for the dentist to keep a track, just to keep all the names and the brands in his head, and then I think it is much easier for you at least to know the classification of the material, just to have an idea about what type of this material. Is it glass? Is it polycrystalline? Is it polymer containing? And that will give you an idea about, for example, the properties, the mechanical properties, the optical properties. And to be honest, different classification of dental ceramic are there. And this include, there is a classification according to composition. So as I mentioned, different classification according to the composition could be either glass ceramic, or could be polycrystalline ceramic, or it could be like ceramic-like material, as I mentioned earlier. Again, another classification can be according to centric temperature, which can range from 700 to up to 16 or 1700 degree. And also another classification is about processing method, whether you're using CAD/CAM, or you are using a slip cast technique and a press technique. And usually this is lab, I would say that the classification that's going to be more lab related. Probably you won't be knowing too much about it. Fracture resistance, the strength of the material, like a high strength ceramic, low strength ceramic, abrasiveness, how abrasive is the material, and also optical properties. And to be honest, there's a lot of classifications of dental ceramic, but today I'm mainly focusing on composition of dental ceramic. Right, okay, so types of ceramic based on their microstructure, and this classification is based on the old definition, which is, as I mentioned earlier, and it divides ceramic into three main categories, which is the glass ceramic, which is the most aesthetic one, and it is called feldspathic ceramic, and the ceramic which is most commonly used for veneering or for layering all ceramic restorations. And also we've got the particle fluted glass, which is the lithium disilicate. And then we've got the polycrystalline, which is the strongest one. For example, the zirconia and it is not porcelain. So the word porcelain, it's been used interchangeably with a ceramic. Just to make it clear for you, it's all porcelain are ceramic. All porcelains are ceramic, but not all ceramics are porcelain. So basically, anything containing glass, we can call it porcelain, but nothing without. So and ceramic without glass, for example, zirconia, we can't say this is a porcelain. So just to make it clear, sometimes people get confused with this one. And yeah, in 2015, Graces came into suggested a new classification for the dental ceramics and the ceramic-like material. And this allowed him, as I mentioned earlier, this allowed him to include the resin matrix ceramic. We're going to talk about that later a bit. So the main three categories is the glass matrix ceramic and the polycrystalline ceramics, and also the resin matrix ceramic. So the glass matrix ceramics, as you can see, it's divided into feldspathic, synthetic, glass infiltrated, and polycrystalline, including the aluminum, zirconia, stabilized zirconia, and the resin matrix ceramic, basically mainly formed from polymers and including different refractory ingredients, probably porcelains, probably ceramics, so different types of glass, different types of glasses. For example, you got like lava ultimate or enamic or all these type of material. It's going to be very difficult to talk all of these materials. However, I'm going to talk mainly about lithium disilicate, which is the most commonly used, as I mentioned earlier, dental ceramic in the world, about hundreds of millions being used till nowadays. And also I will talk about the dental zirconia, stabilized dental zirconia, right? Okay. So is everything clear so far? If anybody else got a question, please just post your question in the chat box or the Q&A. Right, okay. Now, we are back to the main subject for today, which is zirconia versus lithium disilicate. Which way to go? Which material to choose? Okay, in order to be able to decide which material to choose or which material to select for your preparation or for certain patients type, we need to know more about the material. So we need to know a little bit about zirconia, a little bit more about lithium disilicate, and then we take it further from there, and so we can decide which material to choose. Now I've got another question for you. Assume that you are just a prepared lower first molar tooth or lower second molar tooth, and you decided to do that zirconia, just to replace that, or just to, the restoration is going to be zirconia crown. So my question to you is, from this highlighted in the red box, which zirconia are you going to choose? Which one you will choose and why? If you can, you know, I don't need the answer at the moment, or basically, well, you can answer in the chat if you want to, but I forgot to mention that the patient that you prepared the tooth for him or her is the patient is a bruxising, so it's got a clenching habit. So which one are you going to choose and why? Right. Okay, we'll come to we'll come back to that later. Now we're going to talk about zirconia as an unalloyed material is available in three phases, which is the monoclinic, tetragonal, and cubic phases. Each phase of this material has got different optical and mechanical properties. But unalloyed zirconia is unstable at room temperature, and tetragonal can easily transform to a monoclinic, and if it is unstabilized. And all the phases are temperature dependent. So for example, if you raise the temperature from room temperature to more than 1170, you get tetragonal, and so on. Okay, so in order to stabilize the zirconia, a dopant has been added to the zirconia, and the most commonly used dopant is the yttrium oxide. Okay, but different dopant has been added to zirconia, magnesium, cerium, but the most commonly used oxide is yttrium oxide, and the amount of yttrium oxide by volume, I mean the added to the zirconia by volume, will determine the strength and also determine the optical properties of the material, and also will decide which phase is going to be the material in. So, for example, I'm going to talk about that later on, and the amount of yttrium at the end is going to affect the grain size. Okay, the less amount of yttrium, the less grain size, which is the crystalline, the trigonal phase, and the more amount of yttrium you get the cubic phase, and it will be more grain size. I will tell you why I mentioned about the grain size, because it's got really a good. It's really related to what I'm going to talk later on. Right. Okay. As I mentioned, the amount of the dopant is really determining the phase of the zirconia. Adding about 3% by volume, yttrium oxide to monoclinic zirconia will result in a metastable tetragonal zirconia, which is the most strong, the material, the phase with the highest strength in zirconia, and the most stable type of phase of zirconia after adding the dopant. As I said, it's 3% by volume. So the secret, I would say, or the reason behind the strength of the high strength of tetragonal zirconia, we can call it a self-healing material, basically. So as you can see here, okay, changing from tetragonal to monoclinic will result in an increase in the volume, okay, about 3 to 5%. Okay, if there's a crack on the surface of zirconia, tetragonal zirconia, this crack will introduce, this crack will result in transformation of the tetragonal, or the pressure from the crack will result in the transformation of tetragonal to monoclinic phase. And this is, as I mentioned earlier, this will result in the change in the volume of the zirconia and will act as a self-healing, so will halt the propagation of the crack. And this is what is called the transformation toughening mechanism of zirconia. And well, simply this is explaining the high strength of zirconia, mainly trigonal phase. Now I've got a question for you. And do you know how many generations of dental zirconia are there in the market, and what are they? If you can post into the chat for me. Yeah, we're getting some answers. Monolithic, cubic. What else? Anybody has got different answers? Right. Okay. So zirconia are available in 3 main generations nowadays in the market. I think the 4th generation is coming very soon, or might be already in. And these are the 3Y, 4Y, and 5Y zirconia. The Y referring to the amount of yttrium oxide. So the 3Y zirconia, it is the 1st generation, and then the 4Y generation, and then the 5Y generation came up. And the amount of translucency and the strength is, as you can see, highlighted by this arrow. So as we move from 3Y to 5Y, we will get more translucent zirconia. But if we move back, as you got the high strength zirconia is the 3Y, and this is mainly because tetragonal phase. However, increasing the amount of dopant to 4Y resulted in about 25% of a cubic zirconia, which has got a bigger grain and which allow more light transmission. And we'll talk in the next slide about that. And then you've got the 5Y, which is has got about 50% cubic zirconia, and the rest about tetragonal. Right. This is an ACM images that it's been done for both of them zirconia, and both of them are the same magnifications. And on the left-hand side, it is a 3Y zirconia, and on the right-hand side, it is a 5Y zirconia. I talked a lot about dopant, effect of yttrium, and about the grain size. Okay, so the smaller the grain size, the more grain boundaries, as you can see in this SEM images. All these boundaries will act as, will cause the light to diffract, okay? Cause light diffractions. However, on the other side, the cubic zirconia has got a larger grain size, and larger grain size, so less boundaries. So the light would pass more smoothly through cubic zirconia. And this diagram explaining or just showing you the difference between 3Y and 5Y. So the 3Y, we call it anisotropic material. So basically you can get different values if you put the light in different directions. And this is mainly due to the arrangement of the atoms and the grains inside the material, which can result in light diffraction. While the cubic phase that we are talking about, is allowing the light to pass without any diffraction, right? So this is all about zirconia at the moment. And we were going to move now to talk about another type of dental ceramic, which is the lithium disilicate. The lithium disilicate, as mentioned earlier, it is the most commonly used dental ceramic in the world, and hundreds of millions being placed till nowadays, simply because this is, the type of the dental ceramic, it's a particle-filled glass ceramic, and it is being introduced, as I said, in 1998 by Ivo Clar, and still being used nowadays. And it is simply because it's high aesthetic material and a very good mechanical properties, and also made the digital workflow much easier compared to using metalloceramic crowns. In this slide, I will show you the average of the flexural strength, or the strength of all ceramic materials. As we move, like from the feldspathic, like you can see the range is really very wide range of this is all ceramic restoration. And all of them can be used for the all ceramic restoration. And you see the range is from 180 megapascal, the strength of feldspathic porcelain, which is the most commonly used ceramic for veneering or for the layering of the core material, up to 1200 megapascal for the zirconia. This is the 3Y zirconia. And this is, here in this slide, I've been a bit optimistic, and I'm showing you the highest numbers that we can get from these materials. But as we go, like the material with the high strength is always the most opaque material. And as we go to the other side, to the less strength material, we get the more translucent material and the more aesthetic material. Right, here now I've got another question for you. I'm going to put in the chat box, and if you can tell me what you can see, what is the difference? So what is the difference? Is there any difference, anything that you can pick up between the four picture? So to make the question much clearer, which tooth being replaced, which tooth being crowned? Which tooth has a crown on it? Right, okay. Can you figure any difference between all of them? So that's right, this upper right one has got a crown on it, and all of them has got a crown on it. So which one do you think the most, mimic the natural tooth structure? Which one is you find it, or you can see the most natural looking one? Right, okay, so I'm going to give you the answer now. Okay, we're going to take, the answer is still relative, so basically everybody has got different opinion, but this probably would make it more clear. So this is the upper right one that's been prepared, and it's been replaced by 4 different ceramic restoration. And we'll show you the difference. So the first one that we've got here with the upper right one, it is a PFM with 180-degree shoulder finish line. And on the 2, we've got the 360-degree, again, PFM with 360-degree finish line. While on the third one, we've got the all ceramic restoration, which is the core made from Procera, which is the all ceramic. And then this one made mainly from monolithic restoration and mainly from glass ceramic. Okay, so this just to show you like the difference between all these. So all of them, 1, 2, 3 are layered restorations. Only this one is monolithic. And if we go back to see, well, some of the people, they say that this is the most natural looking tooth. Again, different people have got different opinions, but we're going to talk more about the layering and the problem of layering. Just to make it clear, when we say monolithic restoration, so basically we mean like only one layer, so there's no core and veneer on the top of it. And the monolithic restoration, as lithium desiccate, can be used for monolithic restoration. And also, this is zirconia core and being veneered by feldspathic porcelain or usite porcelain. And but nowadays, zirconia also available as a monolithic restoration. Right. Okay. So, I was talking about the problem of about the layering, about monolithic and layered restoration. Zirconia when first introduced into the market, mainly used for core material, and it was like it showed a high success rate, like in terms of the strength. But the main problem, still up to nowadays, is the chipping of the dental porcelain. Okay, the chipping. As you can see, there's like a chipped. Well, some of the chipping doesn't affect the function of the restoration, and some of them really affect and need replacement. However, in the literature, the recommendation is to replace any defective restoration. Here in this slide, just try to collect all the survival rates of all ceramic restorations for you. And I've looked into different systematic review and some of the clinical studies for 5 years, 10 years, and also some lab study. Well, all ceramic restoration has showed really a good survival rate, but this can be ranging from 70 up to 95%. It depends. This variation depends on the type of a study, on the type of the, again, the number of type of the study, type of the material being used. Again, a lot of things, contribute to the success rate, basically, of any dental restoration. Okay, the lab made it, and the type of material used. And to be honest, these, not all of them the same, for example. But for example, some of them, they looked at a 3-unit bridge, and some of them looked at only single crown, and some of them, but all of them are about all ceramic restoration. And some of them, the core was zirconia. Some of them, the core was alumina or lithium disilicate. What I want to highlight and to make it clear that the delamination problem is the delamination or the chipping problem of veneer is the main reason for the failure of the all ceramic restorations. So, for example, I got right here, this is a study in 2012 looking at 5 years survival rate of all ceramic restorations. As you can see, it's about 79% the survival rate of the restorations, and 31% is the chipping. However, not all of the chipped material being replaced. So basically, some of them they're being repaired inside the mouth. But it is the recommendation in the literature just to replace any restoration with a defect, because the chipping can get bigger and bigger even if you repair it. And to make it clear for you now, because we are talking about zirconia layering or talking about lithium desiccate layering, the zirconia layering, the layering of zirconia and the incident rate of a fracture or chipping of that, it's been reported about 3 to 36% from 1 to 5 years for 3-unit bridges. Okay, and these numbers are mainly for zirconia core. Okay, and the chipping of for the single crown from 1 to 3 years, it is 2 to 9% the chipping rate. Zirconia is still relatively a new material, and still there's not too much studies about it compared to the metalloceramic crown. So still under investigations, and even the different types of zirconia still under investigations. right? Okay. Now I got a message for you, the take-home message from this presentation, and to make it like much easier for you and to conclude. So different scenarios require different material. Not all the patients are the same, and I'm sure you are aware of that one. So and so different, it depends on the patient. If the patient is processing, if the patient suffering from tooth wear, if the patient has got poor humidity control, so you cannot use, for example, anything to bind with a resin cement. So you need to think about using another solution that you can cement it with a conventional cement. Knowledge of the material you use is the key for the successful treatment plan. So really try to your best to know about the material, or what material you are using. And for example, as I showed you earlier with the lab card, which material to choose. When you choose the material, whether that's zirconia, like solid zirconia, or translucent zirconia, or layered zirconia, you have to choose it on a sound base. You know what you are choosing and why you are choosing it. I got another message, which is zirconia should be used with caution. Basically, zirconia is a very good material, and its optical properties is good. But I'm sometimes I really get surprised when patients use like doing zirconia veneers. So what is the reason behind that? I don't know why, but anyway, again, I think they must have their justification, but I wouldn't recommend using zirconia for veneer, for example, for the anterior teeth at all. Lithium disilicate is there, and I can use it. It has got a very high success rate and a very good aesthetic result. And here we got what to choose in different scenarios. Just to give you, like, as I said, a rough idea. I can't talk about every single scenario. Right, okay. If you got like high aesthetic demand with limited tooth structure loss, my first choice is going to be porcelain. I'll use basically the porcelain or the feldspathic porcelain for veneering, for example. And also the second choice is going to be glass ceramic material. If I got, again, an aesthetic demand, okay, and a high aesthetic demand and a large tooth structure loss, I would go with the glass ceramic first. I always try to use glass ceramic first. Again, I'm talking about monolithic restoration, not layered one. Okay, and the second choice is going to be monolithic zirconia. Okay, now we've got the monolithic, which is the translucent zirconia, so we can use it. Poor preparation, such as excessive taperness. So again, I will choose glass ceramic. I'll tell you why. Because glass ceramic is got like, you can bond it using the resin cement, and it is well known that it's more reliable than bonding zirconia with dental with the resin cements. So I would choose glass ceramic again for poor preparation or like excessive taperness. Again, you need to think about, for example, I mentioned earlier, if there's no enamel, there's no, on the other hand, if there's not enough enamel to use adhesive, for example, to use like resin adhesive cement, I would go and choose zirconia and monolithic zirconia and use like just conventional cement. And again, the same, if I got like difficulty in controlling humidity, again, resin cement might be difficult to use. So I will go and use the monolithic zirconia. Here we've got heavy discolored tooth. So the heavy discolored tooth, if you are struggling to basically to hide that discoloration, and it's very like a root canal RCT, root canal treated tooth, and you want to to hide that severe discoloration, you can use monolithic zirconia. Monolithic zirconia, that's right, it is translucent. However, it's never been going to be translucent as lithium disilicate, which is the glass ceramic. When I say here glass ceramic, I'm meaning lithium disilicate. So, I would use monolithic zirconia because it still has got a degree of opacity which can hide the shade, of the shade that you don't want to. And also, you can use here a bilayered like zirconia, the zirconia core with the veneer, like for feldspathic porcelain veneer, whatever on the top of it. The question was about the bruxism, okay? And when I asked you about what the patient was bruxising, and you want to choose the zirconia, which zirconia we choose? I always choose monolithic zirconia because the bruxism patient has got more force applied onto the tooth, and if you use the bi-layered one, there's a high chance of failure of the veneer on the top of the zirconia core. So I always would go with the monolithic zirconia. And to be honest, I'm not quite sure how important it is. Like, you know, I don't think that's really very important to use like a highly aesthetic material on, for example, on the lower or the second molar or the first molar. Even like, is it how much difference going to make using you know, like more translucent material? So I would go with monolithic zirconia. I think it's the best solution to get for bruxism patients, and also patient with tooth wear. Patient who is suffering from tooth wear, what you can use basically, I would go with zirconia, and again monolithic zirconia, because porcelain is more abrasive, like causing more tooth wear compared to zirconia. So zirconia is more benign, especially when you've got antagonist natural tooth. So it is less abrasive and it's more benign, more kinder to the tooth. But if you use, in this case, a bilayered restoration, for example, zirconia, and on the top porcelain, we've done nothing basically, again, because the facing is going to be porcelain. And again, we've got the same problem. That's going to be the loss, that's going to be, again, causing the tooth wear more abrasive and causing the tooth wear of the antagonist natural tooth. Right? Okay, in a nutshell, to conclude, it's my recommendation today is try to use monolithic restoration whenever possible. Okay, so whenever possible, try to use, and I think you will be able to use it most of the time. Use like lithium disilicate for anterior region. Okay, whenever you got an aesthetic area, like it's from canine to canine, even for the premolars, you know that lithium disilicate, we can use it up to 3 units to make up to monolithic 3 units of bridges, including the premolars. So I would always go in the interior. First thing I would like to think of when I want to replace or do a restoration in the anterior teeth, I would go with lithium disilicate, or what is known as Emax CAD or Emax Press. Use monolithic zirconia for posterior region. And the last thing is try to achieve a minimum 1 millimeter preparation for all ceramic restoration. Right, okay, so well, the last point, well, a lot of things in the market now, a lot of the material that are claiming that you can use 0.6, 0.8 material. However, there's no like clinical studies about this material in vivo, like how successful these material are. And just to make it clear, all these material, like for example, a claiming strength of 500 megapascal, this material has got, which is good, which is still you can use it for crown, for molar, and also for bridge. But these all tested at a thickness of 1 millimeter or 1.2 millimeter thickness, as according to the ISO standard for the dental ceramics. If you are making, you know, if you are using a smaller, a smaller, less thickness, for example, 0.8 or 0.6, that's definitely going to affect the mechanical properties of this material, and is most likely is going to be chipping at the margin, okay, which can cause you a trouble, and then you will need to restore that and you will need to replace it. And thank you for your attention. And this is the end of the webinar today. And if you've got any question, I am back now to Catherine. Catherine, can you hear me now?
Hi there, Aziz.
Hi.
Okay, so let me just have a quick look. Okay, so there's one question here. How easy is it to remove section zirconia?
How easy is to remove, sorry?
Section zirconia.
Well, so to be honest, the question is not really clear. What do you mean by section zirconia? So, well, basically, if you want to remove it, like a failed restoration, I would use, you know, probably beaver's bear, like, you know, a high-strung bear to remove it, if that's the question. I'm not quite sure what sections are going to be honest.
So we have another question here. What material would you use to restore implants? What ceramic is the best if the opposite teeth are restored with composite? Thanks a lot and very good presentation.
Oh, thank you very much. That's fine. Thanks. That's really interesting question. Well, for implant, you can use both zirconia or lithium disilicate. To be honest, I'm a big fan of lithium disilicate. I find it is very successful material, and it's got really high aesthetic material, and also it's highly, you know, a good mechanical properties, and also has got really good aesthetic results. As I mentioned, patient like a different patient, like for example, existing patient with tooth wear, I would go with zirconia. So both of them, it depends, to be honest, on the situation, but always I go first for the lithium disilicate, then my second choice is going to be zirconia. And I think that there's another question, which is, yeah, what material to use if you've got the antagonist as a composite? Again, I would use, well, if we are, you know, if we want to avoid the wear, I would go with zirconia, basically. So as I said, it's less abrasive than glass ceramic, and glass ceramic is more abrasive and can cause a tooth wear. And again, if a glass ceramic causes a tooth wear to a natural tooth, and definitely is going to cause more tooth wear, wear to the composite restoration.
Okay, so I think that's about it, isn't it, now with the questions? So, Aziz, thank you very much.
Oh, thank you very much. Thanks, Catherine.
I think maybe just one has just popped up now. What margin do you prep for zirconia?
Zirconia, use chamfer. Shallow chamfer is fine. Okay, chamfer or shoulder, but I would go with shallow chamfer. Is fine. I would really, you know, nowadays a lot of people talking about the feather edge or knife edge, but there's a lot of report about the cracking of the margins. So I would use chamfer edge finish line. You will get a great result from that.
And there's another, well, they're all coming through again now, Aziz. So what are your thoughts on the success of zirconia bridge work and the connector height thickness needed?
Right, okay, well, the main, again, are we talking about the monoclinic, or sorry, are we talking about the monolithic or the layer zirconia? So the main reason behind the failure of zirconia bridge is the failure at the connector area. As we know, like, you know, you need to take a lot of the tooth basically to get a good connector between usually they fail at the connector area, and you know the recommended to get a good connector is about 9 millimeter square millimeter. The area of the connector should be at least 9 millimeter square millimeter. So, but I think the zirconia bridge has got really a good result, or has got a high success rate if it's been prepared and being planned properly. I think, and again, I would go with monolithic zirconia rather than layered zirconia.
Okay, and just one more here. I think you may have answered it more or less on your last one. What material would you use for crown root filled teeth?
For what, sorry?
For crown root filled teeth.
Crown root filled teeth. Okay, well, you can use any, basically. You can use either lithium disilicate or you can use zirconia. And as I mentioned earlier, if the tooth is really discolored and you want to avoid the discoloration showing through the restoration, I would go with zirconia.
Okay, perfect. Thank you very much. Oh, here we go, one more.
That's fine, go ahead.
Which burrs and handpiece would you use to cut through a zirconia bridge? I think you answered some of that before on one of the other previous questions about the chamfer burrs. To
be honest, you can use any burr to cut through that, but I would use is the question about removing an old restoration, or is it or adjusting? So can you repeat the question for me, Catherine, please?
So which burrs and handpiece would you use to cut through a zirconia bridge?
Okay, well, I would use the high speed handpiece with beaver's burr. It's called beaver's burr.
Okay.
Okay, it's a very strong burr that can cut really easily through the zirconia.
Okay, perfect. So Aziz, thank you very much. That's all the questions answered. Okay. I hope you enjoyed that yourself.
Thank you very much. Thanks.
Okay, so we do appreciate it. So enjoy the rest of your day, and thank you for helping us with the webinars.
Thank you. Thank
Okay,
you.
take care.
Thanks. Bye-bye. Bye.
Bye.